Good afternoon. Okay, so we will start with the cerebrospinal fluid analysis today. Yesterday we did the lecture about meningitis. So I hope you have understood the meningitis causes, complications. So we come to the CNS series of lectures which states about cerebrospinal fluid analysis. So definition. What is cerebrospinal fluid? Cerebrospinal fluid, as the name suggests, it's the fluid which encircles the brain, which protects the brain from outside. It is within the brain parenchyma. It is secreted via the brain ventricles, the epithelium lining the brain ventricles, and spinal canal. So the liquid surrounding the brain and spinal cord flows in subarachnoid area, that is subarachnoid space between the arachnoid meter and the pia meter, the space between arachnoid and pia meter. The main functions of CSF are protection of brain from mechanical trauma, to provide new. So the functions are nutrition, to provide buoyancy to the brain, to protect the brain from mechanical trauma, and to maintain the structure of brain and excretion of waste products. So properties of CSF are: CSF is a clear fluid with specific gravity of 1.005, same as of water, and the reaction is alkaline. The rate of production of CSF is 0.3 ml per minute, and there are approximately 3 to 7 times the CSF turnovers in the whole day. So the volume is 150 ml. There is continuous secretion, continuous absorption into the blood, and recycling. So CSF formation and circulation, it needs to be understood, because you needed to understand the pathophysiology of hydrocephalus, the pathophysiology of CNS infections, the pathophysiology of raised intracranial tension. So this formation and circulation of CSF is important. Site of formation is, we have already discussed, it is choroid plexus situated within the ventricles. Choroid plexus are the tuft of capillary projections present inside ventricles, and they are covered by pia meter. So the CSF secreted is within the ventricles. They are secreted within lateral ventricle, then they go into the third ventricle via foramen of Monro, then they enter via Sylvian aqueduct into the fourth ventricle, then via foramen of Luschkas and foramen of Magendie, they enter the central spinal canal. So mechanism of formation is by selective ultrafiltration of plasma, and there's also active secretion by epithelial membranes. So this is the diagram showing the flow of CSF from foramen of Monro. From lateral ventricle, they enter third ventricle via foramen of Monro. Then they enter fourth ventricle via cerebrous aqueduct of Sylvius, and they from fourth ventricle they have 3 openings. They enter into the lateral apertures via foramen of Luschka and into the subarachnoid space, and then into the central canal of spinal cord via foramen of Magendie. This is not a very clear picture of CSF, so you can understand all the 4 ventricles, lateral ventricle, third ventricle, fourth ventricle, all of them are situated in a 3-dimensional space. So lateral ventricles, there are 2 lateral ventricles which drain into a third ventricle, which is vertical in shape. Then it drains into the fourth ventricle, then it drains into the subarachnoid space, and also into the central spinal canal. And the flow is maintained. From subarachnoid space, it is again absorbed into the blood, and from blood, it is again secreted by choroid plexus into the ventricles. So it is absorbed by arachnoid villi into the dural sinuses and spinal veins. Small amount is absorbed along perineural spaces into the cervical lymphatics and also the perivascular spaces. Normally 500 ml of CSF is formed every day, and there is a turnover of around 3 to 7 times per day. So the diagram showing choroid plexus of ventricles producing CSF, then CSF entering into the circulation, into the ventricles, then via foramina into the spinal canal, then into the subarachnoid spaces via absorption. From arachnoid villi, then it enters, then the byproducts enter into the blood, and again from blood the choroid plexus of ventricles secretes CSF. So biochemical analysis of CSF is very important, as we discussed in meningitis yesterday. Not only in meningitis, CSF examination is also very important in certain inflammatory diseases, in demyelinating diseases, in malignant diseases, in primary and secondary malignancies. So, what are the main tests we carry out in CSF? Glucose, proteins, albumin, immunoglobulins, cells, lactate, and cells, of course. It is the most reliable diagnostic accessible test because it gives you a direct idea of what is happening inside the brain. So indications of CSF are absolute indication, meningitis, subarachnoid hemorrhage. Relative indications are neurosyphilis, unexplained coma, Guillain-Barré syndrome, multiple sclerosis, demyelinating diseases, malignant diseases. So these are the indications of CSF examination. Also, when we performed myelography and pneumoencephalography, sometimes CSF is indicated. Therapeutic indications of CSF are CSF examination. One, when we want to administer any drug into the central nervous system, example methotrexate. We give methotrexate bi-weekly via lumbar puncture in cases of acute lymphoblastic leukemia and acute myelogenous leukemias. We also give gentamicin in gram-negative meningitis, which usually occurs in extremes of ages. Then we also give crystalline penicillin in 10,000 and 20,000 units in pyogenic meningitis. To reduce intracranial, but crystalline penicillin is now obsolete. We usually give IV antibiotics instead. To reduce intracranial tension in hypertensive encephalopathy, this indication is also very rare, but in earlier days, people used to carry out such CSF drainage in cases of hypertensive encephalopathies. And to administer spinal anesthesia. So when we're talking about intracranial tension, the most common indication of therapeutic drainage of CSF these days is in normal pressure hydrocephalus. Normal pressure hydrocephalus, this is an entity also known as pseudotumor cerebri. Contraindications of lumbar puncture. The absolute contraindication of lumbar puncture, as we all know, there should not be any local skin infection, which can lead to introduction of surface bacteria into the CNS. So there should not be any local skin infection. There should not be any intracranial mass lesion, which causes highly raised ICT, because if we drain CSF at that point of time, it may lead to herniation of brain into any orifice, like it may lead to herniation of uncal part of the temporal lobe into falx cerebri and into the posterior fossa. It may lead to tonsillar herniation. It may lead to midline shifts. So highly raised ICTs because of intracranial mass lesions are absolute contraindications to lumbar puncture. Related contraindications are, of course, raised ICT, except pseudotumor cerebri, which is an indication for lumbar puncture. We also discuss this as normotensin hydrocephalus or normal pressure hydrocephalus. So that is an indication of therapeutic drainage of CSF. Otherwise, raised ICT is a related contraindication, and we have to perform guarded CSF examination in such cases. So, uncontrolled bleeding diathesis, any bleeding diathesis causing deranged bleeding and clotting parameters like deranged PT-INR in cases of any known underlying liver disease, in case of immune thrombocytopenia, in case of DICs, consumptive coagulopathies, wherever there are deranged coagulation and bleeding parameters like platelets, PTINR, APTT deficiency flooding factors, there is related contraindication. Then spinal column deformities, because it is a blind procedure usually, so if any spinal cord deformity is there, you may tend to injure the spinal cord. And you may also require fluoroscopic guidance for that. So this is a procedure, we discussed it yesterday also. How do you identify L3, L4 space? L3, L4 space is usually identified by iliac crests. So what do? You identify two tips of iliac crests, and then you draw an imaginary straight line. It usually passes through the middle of L3 and L4 space, and that is your spot to enter the needle. Since cord ends at lower border of L1, you are safe in that space. There is just CSF and chorda equina over there, so you enter the needle. You don't injure any nerve or spinal cord over there. There's plenty of space, and you can draw the CSF. The positions for CSF examination are lumbar puncture as knee chest position, or sometimes if the patient is conscious, you can also ask the patient to sit with legs down forward, hanging from the bed, or in the palki position. You can ask the patient to bend forward completely. What are the complications of lumbar puncture? Lumbar puncture, the most common complications are post-lumbar puncture headache. And to prevent this, what do? After lumbar, just immediately after lumbar puncture, you ask the patient to lie supine for at least 6 hours with no headrest, with no pillow under the head, and to raise the legs by at least 15 degrees while lying supine. So you can put a pillow under the legs of the patient, and you ask the patient to lie supine without any lateral turning for next 6 hours. Also replace some fluid in the form of IV fluid if the patient is dehydrated. So you can replace 500 ml of IV fluids also, isotonic saline. And introduction of surface infection is another complication we've already discussed. You can introduce the surface commensal bacteria like Staph hominis, Staph saprophyticus. You can introduce inside the blood, and they can cause CNS infection, nitrogenic CNS infections. Another complication is subdural hematoma, and if an inexperienced person is doing a lumbar puncture, he may injure the small artery vasa nervosa medanta nerves. You can injure the arteries and capillaries feeding the vein into the puncture, so it may lead to subdural hematoma. And another complication is failure to obtain fluorescence. Sometimes, again, due to inexperienced hands, or because of the faulty posture, or because of the low intracranial tension, you may also obtain a dry tap. Herniation of brain, we have already discussed. In case of intracranial mass lesions or VSICT, if you perform CSF examination, you gain a lot of CSF, more than 8 ml, you may cause herniation of brain into the different foramina. Subarachnoid epidermolysis is always is one of the very rare complications. It usually occurs when you withdraw the needle amount of the arachnoid layer. It comes down with the thick formation within the so it will come out forming a small stick of arachnoid layer inside the skin. So epidermal sticks are usually formed. This is a rare complication. Physical examination. Normal CSF is colorless, clear, transparent fluid, no clots, no blood. If CSF is cloudy or turbid, it is due to either leukocytes or due to proteins inside the CSF, exudates. So this is a picture showing different types of CSF. In first picture, you can see normal CSF compared to the xanthochronic CSF. Xanthochronic CSF is because of the parenchyma. proteins inside the CSF. Then also, sometimes when there is a long-standing hemorrhage inside the CSF, like this is a subarachnoid hemorrhage, the blood protein tends to undergo lysis and is converted to bilirubin and bilirubin. Maybe somewhere in the passage, these proteins are formed, so also during the appearance of xanthochromia inside the CSF. So, xanthochromia CSF is found in subarachnoid hemorrhages. The next picture shows clear CSF or normal CSF on the left hand, and it shows turbid CSF on the right hand. Very characteristic of pyogenic meningitis and tubercular meningitis because of the presence of exudates. Then in the next picture we also saw this picture yesterday. It is the picture showing cobweb coagulum. It is seen in tubercular meningitis. And in the last picture, this is a faulty traumatic tap. So blood degradation products in subarachnoid hemorrhage leads to xanthochromia and CSF. Also the proteins which are exuded along with the blood. So, and the last one is the traumatic tap. You can see the precipitate over here, the clot formation, and this is the supernatant liquid which is left. So this is imparting a pinkish hue to CSF. This is a traumatic tap. This is the picture we saw yesterday. Actually, every book says a different picture of CSF, but by far you can remember this, as I told you yesterday, that acute pyogenic meningitis tends to decrease glucose to a very low level inside CSF, and tubercular meningitis, since it is well known for high amount of protein exudates, it leads to an increased amount of protein in CSF. So that is a very important line to remember. This is what is given in Harrison, which I'm telling you. This chart was actually prepared from internet. So as you can see, the normal CSF has a clear appearance, 90 to 180 mm of mercury pressure. WBCs are usually absent or very less in amount, usually lymphocytes. Normal protein is 15 to 45 milligrams per deciliter. Glucose is usually 60 to 70% of the blood glucose. If the normal blood glucose is considered as 70 to 140 milligrams per deciliter, so the normal CSF glucose would be 50 to 80 milligrams per deciliter. Fluoride values are 115 to 130 milligrams per liter. What happens in acute bacterial meningitis? We get a turbid appearance of CSF with increased opening pressure. WBCs are highly raised. They are in thousands, and they are polymorphonuclear cells mostly. Proteins are raised. They are 2 to 3 times at least raised. Glucose are very less. They are less than 40%. Or we can also say if the normal blood glucose was found to be 100, then they are less than 40 milligrams per deciliter. Fluorides are usually decreased. Because bacteria produces an acidic medium inside the CSF. In viral meningitis, the picture is usually mimicking the normal CSF picture. Everything appears to be normal except for the cells. The cells are usually within hundreds to 500 grains in viral meningitis, and they are predominantly leukocytes. They are predominantly leukocyte cells. So, and in tubercular meningitis, the appearance is opaque again with high opening pressure, with cobweb coagulum formation, and proteins are highly raised, glucose is decreased, cells are usually more than 500 to 1000 lymphocytes. Fungal meningitis is a rare complication of immunocompromised cases. The appearance may be clear, may be turbid. The pressure is usually increased because of the exudate formation. The cells are predominantly lymphocytes. Proteins can be between 2 to 3 times greater of the normal level. Glucose is usually decreased. There is no absolute value between the five. And fluorides are usually decreased. So, the important thing to remember is the glucose, the protein, the cell type, and the amount of cell units. Abnormalities of CSF. Physical abnormalities can be high CSF pressure because of raised intracranial tension, like in infections, in intracranial lesions, in case of normal pressure hydrocephalus, in case of non-communicating hydrocephalus. Blood stain can be in traumatic puncture, can be in subarachnoid hemorrhage, xanthochromia is usually present in jaundice, subarachnoid hemorrhage, Crohn's syndrome. Turbidity increased because of increased cellularity and increased exudation of proteins and complex formation of usually present in tuberculosis. So all these features are asked to be in diagram. Chemical abnormalities may be very low sugar, pyogenic, fungal, carcinogenic meningitis, rheumatoid arthritis, highly rich protein anemia, GBS, demyelinating disorders, low plastic abnormalities, tubercular meningitis. See, why demyelinating disorders? Because myelin is a type of protein. In demyelinating disorders, when all the nerves are undergoing polyradiculitis, like in GBS, they are shedding their myelin sheaths. So all of that myelin sheath, it appears in CSF. So the proteins are highly raised, but the cells are absent, also known as cytoalbuminological dissociation. Increase in cell count is also present in inflammatory disorders. Polymorphonuclear cells are found in pyogenic meningitis. Lymphocytic predominance is found in tuberculosis, fungal, and viral meningitis. Albuminocytologic dissociation is characterized by elevated proteins and normal cell counts in cerebrospinal fluid. You may have elevated proteins and elevated cell count in tubercular meningitis. You may have elevated protein and elevated cell count in pyogenic meningitis. But if there are only isolated raise in proteins but no cells present in CSF, then it is known as albuminocytologic dissociation, usually found in demyelinating disorders like Lambert syndrome, multiple sclerosis, acute demyelination, encephalomyelitis, ADEM. So this was about CSF. Do you have any questions? Do you have any questions? Yes.
What is ADEM, like you last mentioned?
ADEM is acute demyelinating encephalomyelitis. It is a demyelinating disorder, very rapidly progressive autoimmune mediated disorder, occurs because of molecular mimicry. What happens is the whole of the brain, wherever there is myelination, myelin sheath, जहाँ पे भी white matter होता है, it leads to destruction of white matter also in the spinal cord. So all of the white matter formed by myelin sheath, it undergoes degradation and it appears in the CSF. And it is a highly the disease has highly progressive course and it is usually fatal. It leads to seizures, it leads to coma. So ADEM, acute demyelinating encephalomyelitis.
Thank you, ma'am.
Okay. May I know your name? Siddharth. Okay. Any other question? Anyone else? Okay. Thank you.